Thank everyone for joining us here tonight. I'm going to actually go to the phone, and we have a couple of people who are joining us online. So if you could please say your name, your pronouns, and where you're located, and any organizational affiliation if you'd like. So let me unmute. I think that worked. Hold on. Did that work? I think that worked. Hello. Okay, I think, well, we are going to stay where we were on mute, and we're going to roll right into the presentation. So I'm going to go ahead and unmute Stephen Molldrem, and we'll get started. Stephen, are you?
Hi, everybody. Oh, sorry, I had muted myself. All right. Hi, everybody. Thank you very much to the coalition, to Johnny, for everything that he is doing to make this webinar possible today and all the work he does for the coalition. I'd also like to thank, I'm actually out of the States right now, my colleague, Anthony KJ Smith, who's a PhD student at the Center for Social Research and Health at the University of New South Wales, who's provided me with a facility here to present from today. My name is Stephen. I'm going to introduce myself, and then I will let my co-presenter, Nina Martinez, introduce herself. I think that we mostly know each other, but my name is Stephen Molldrem. I'm a PhD candidate at the University of Michigan in the program in American Culture and Science Technology Studies, and I've been studying a lot of the systems and people who work with the systems that we're going to be talking about today for the last 2 years, both in federal policy and among folks who work mostly in Metro Atlanta. So that's me.
Hi, everyone. I'm Nina Martinez. Most of you know that I'm a long-term survivor of HIV, now passing 35 years. So I contribute some data to Georgia Department of Public Health, which we'll get into. I'm also a former public health analyst with CDC's Division of STD Prevention. I was in the Office of Policy Planning and External Relations. I trained in epidemiology because my sole purpose in getting that quantitative experience was to take what data is out there and translate it for folks like yourself, for the general public, for the press, and for policymakers. You know, I'd love if this slide said I was a former person living with HIV. That's going to be awesome. I look forward to that day.
Oh my gosh, I'm former CDC. I'm sorry about that. All right, so we're having this webinar today because understanding existing, new, and emergent uses of HIV data and HIV data systems is important to the broader goals of the HIV justice movement, and because it's been a major finding of mine, and I think it's probably generally known that there's a major knowledge deficit both among folks living with HIV, but also actually among communities of practice and providers who actually administer these systems regarding how they actually work. So we're going to go first revisit today's learning objectives. And I'll let Nina read those.
Oh, give me 1 second. We're going to check on the slide advancement. Stephen, can you hit there you are.
These are our learning objectives, and we really hope that you do get to accomplish all of these learning objectives. So you're going to get a basic understanding of HIV data and monitoring and evaluation practices in Georgia, whether or not you like that, but we promise it's going to be useful. You'll learn about namespace reporting, electronic laboratory reporting, and the HIV Care Continuum. You'll learn about new uses of HIV data in Georgia made possible by advances in health IT, such as the state's out-of-care watch list and the HIV Health Information Exchange. You'll learn about emerging trends in the uses of HIV data in Georgia and other states. Find constructive uses of this data. I promise there's some. Uses of this data for public health action. We'll understand the potential risks posed by use of this data for public health purposes and potential misuse or misinterpretation of these data. It's very relevant for our advocacy work regarding HIV criminalization. And finally, you'll learn ways to incorporate knowledge about HIV data systems into justice and community engagement work. Take it away, Stephen.
Stephen, you may be on mute. Let me see if we can hear you.
Okay, great. All right, there we go. Can folks hear me all right?
Yes. Yep.
Okay, great. So yeah, I'm going to be presenting first today, and what my presentation is going to focus on is HIV data in Georgia and the state's data to care strategy. So following that, Nina will be presenting on an emergent set of practices that are generally discussed under the broad umbrella of molecular HIV surveillance, wherein genetic testing methods are used to track the emergence of particular strains of HIV within populations or for forensic purposes. So at the end of the presentation, we are going to discuss the implications of the content that we are both presenting and then open things up for the Q&A. So we'd ask to hold questions until the end, but if you have questions, if you're in through the webinar and want to put them through to the organizers, please feel free to put those through the chat box. So today I'm going to be talking about HIV surveillance in the United States generally, but really in Georgia, and use of the data by HIV surveillance systems that are operated by state departments of public health. These strategies, often referred to by CDC and other institutions as quote unquote data to care, which is actually a specific stream of funding from CDC and a strategy, use new health IT systems along with clinical and public health interventions to relink people living with HIV who have been identified by state HIV surveillance offices as quote unquote out of medical care. And I put that in quote marks because what out of care means to a surveillance system and what out of care and whether or not someone is actually not engaged in medical care can actually be two different questions. So these data to care systems are designed to basically relink folks who have dropped out of medical care to providers. So surveillance can be a scary word, and rightfully so. So part of what Nina and I are going to be arguing today is that advocates for people living with HIV and people who administer HIV services should be concerned about current uses of HIV surveillance data in the United States and in Georgia, and that collectively, advocates and practitioners should make it a priority to know how various kinds of HIV-related data are generated and how they're being used in the jurisdictions where we work. So specifically today, I'm going to be discussing the state of Georgia's HIV surveillance system, something called the Georgia Out of Care Watchlist, the Georgia HIV Health Information Exchange, and relinkage programs that operate to the distribution of the out of care watch list around the state through a piece of software developed and used by the State Department of Public Health and used by health department staff called the State Electronic Notifiable Disease Surveillance System, or SENS, which you can see the logo for up top. So lots of kind of complex systems and acronyms here that appear very complex and that a lot of us actually work with on a day-to-day basis that we're going to spend some time demystifying. But before we get there, I want to shed some of the baggage that's associated with the term surveillance and define exactly what it is that Nina and I are going to be talking about. So when Nina and I talk about surveillance, we're not talking about the kinds of mass surveillance practices that have dominated uses of the term in the media over the last several years, right? We live in like the era of big leaks and this term gets thrown around a lot. We're actually talking about something a lot more specific. we're talking about a subfield of epidemiology and public health practice called quote unquote public health surveillance, which practitioners just refer to as surveillance for shorthand. So CDC defines public health surveillance. This is from its introductory module to training folks on how to actually operate and work with public health surveillance data as, quote, the ongoing systemic collection, analysis, and interpretation of health-related data essential to planning, implementation, and evaluation of public health practice, closely integrated with the timely dissemination of these data to those responsible for prevention and control, unquote. So I can talk more about the national public health surveillance infrastructures in the United States in the Q&A if we'd like. But what's most important for our purposes today is to know that every state, so I know that there are national partners maybe joining here, every state operates an infrastructure called an HIV surveillance system. And this is generated by the Georgia Department of Public Health as a representation of its HIV surveillance flow, data flow. So HIV surveillance systems are, as that graphical representation shows, incredibly complex, and they actually receive data from many different sources. So HIV surveillance systems collect certain kinds of data on people living with HIV, both at time of diagnosis and on an ongoing basis thereafter. So data collected at time of diagnosis include information on a required case report form. There are separate case report forms for adult cases and pediatric cases that are shown there in one part of the diagram, and that encompasses first and last name. We're all probably familiar with names-based reporting, which gender, and actually now it includes sex assigned at birth and gender identity on the CDC form. Date of birth, home address, likely route of transmission being categories we're familiar with, such as MSM or heterosexual contact or injection drug use, and other vital information. So data collected on an ongoing basis by surveillance systems primarily come from blood work results that are sent to state departments of public health by laboratories from every individual sample of HIV-related blood work that is drawn within a state's borders whenever people living with HIV receive HIV-related medical care. If an individual's diagnosis is not reported via a case report form, when that person receives their first HIV-related blood work, that person will be reported as a new case. And then personnel from the State Department of Public Health and the HIV surveillance unit will work with the medical provider to actually go and generate the information required for that person's entry in the surveillance system that is required on the case report form. So I will repeat this in a little bit of a different way because it's very important to understand moving forward, because the systems that we're familiar with, names-based reporting, the systems that we're talking about today, electronic lab reporting, and then what Nina will be talking about, molecular surveillance, these are all built on top of each other. So it's important to kind of understand how they all fit together. So there's a general awareness of names-based reporting, right, which is that every new case of HIV is reported to the health department and associated with individual names, and that's been in place since 2008. Electronic laboratory reporting, however, is much less studied by folks in the kind of the critical public health HIV justice world, and has been rolled out since 2012 following the issuance of CDC guidance in the form of what's called a Dear Colleague letter, which is a set of guidelines produced by CDC and sent out to state departments of public health as a federal regulatory apparatus. So in the lab reporting paradigm now in effect, I want to emphasize again that every time a person living with HIV goes to their provider for an HIV-related medical visit, their blood work results are sent to the State Department of Public Health by the lab performing the test. The departments of public health are primarily interested in using these systems to measure patterns of engagement in medical care, viral load counts, and rates of viral suppression at the individual and group level, using a framework that many of us are familiar with called the HIV Care Continuum, which allows for measuring patterns of engagement in HIV-related medical care at the individual and group level, as well as for tracking viral suppression rates, rates within a given population, but then also like at the individual level for a person longitudinally over time. So the bottom line in all of this is that for people living with HIV, for every person living with HIV within a given jurisdiction, the State Department of Public Health knows at a minimum, that person's viral load and CD4 T cell count at the time of their last medical visit, the frequency within which they engage in HIV-related medical care, and where they're receiving medical care. And then Nina will talk about other data now that HIV surveillance systems are engaged in collecting in other states and starting starting this year across the country. So I want to be clear again about why it is so important that folks in the HIV community, and particularly people who are advocates for people living with HIV, but also people who communicate with practitioners and practitioners themselves, especially know like the material details of how these systems work. So I've conducted somewhere around 200 interviews with HIV personnel, people who work in LGBTQ health, and public health workers in Georgia. And through this research, I found that the vast majority of people who actually work with these systems, meaning who feed data into these systems or who administer programs through them, and advocates do not have a solid understanding of how data are generated and how systems are structured. And this includes folks who work with them on a near daily basis. So this is a quote there on the left from a case manager who's involved in the state's data to care strategy, which he said to me with a chuckle after I asked him about the out of care watch list and how he actually interacts with alerts that are sent to him through the state's HIV health information exchange through a portal that I'll get into a little bit more details in a moment. But that quote is, quote, "There are times when you do things and you don't understand how it all works, but you just do it." So this is the logic upon which these systems function. They work because everyone plays one small part in a much larger assemblage of people, technologies, and institutions that is actually very difficult to fully see, especially if your job is to perform one specific function or a range of functions, such as being a linkage navigator, or in this case, now we have relinkage navigators, or if you're a case manager, or even if you're a doctor. Everyone's kind of playing a role in the support of these systems. So folks in the community of advocates and who work with these systems also don't know the details about how they function, because we as communities of advocates and decision makers who administer these systems have actually chosen not to prioritize the dissemination of this knowledge. So it's an intentional decision to not, and demystify these systems for everyone who works with them. So the effect is that very few people outside of those who administer systems at a very high level understand much about how the data and the systems that they work with on a daily basis. And many of these are used to, many of these kinds of data are used to target people living with HIV for exceptional kinds of monitoring and clinical and non-clinical interventions. They just don't actually understand where these data are coming from. So this would obviously not be accepted for any other condition, pretty much, and doesn't exist for any other condition. We don't have, for example, there are some similar infrastructures being developed around prescription drug monitoring programs, but they're not as onerous as this. We don't have, for example, surveillance systems for hypertension, right? This is really a case of, what in the literature is called HIV exceptionalism. So I want to be clear that in saying that people who work with these infrastructures do not fully understand how the systems work, I'm not saying that people don't know how to do their jobs. What I am saying is that many who work in the field haven't been equipped with the knowledge to understand where the data they work with come from, how the data got there, who produced the data, and what systems the data have had to move through in order to get to whatever point in the workflow that an individual actually uses the data for some specific purpose. For example, using data from the out-of-care watch list to link someone to care, relink someone to care in a clinical context, or to send a letter to their home, to call their home and to leave them a message, or to even visit them at home without their prior notification, all of which are central elements of Georgia's data to care strategy and data to care strategies in other states. And even though most people don't fully understand these systems, as I've said before, we're all a part of them and we're all implicated in their ongoing operation. So, whether we're advocates or, as Nina mentioned, she's a person living with HIV, their data are, folks' data are always going into these systems, but even if you're only working with, for example, an electronic health record, you're feeding data into these systems. We're all implicated in their operation. So therefore, understanding them provides practitioners and advocates with opportunities to better serve people living with HIV. Ongoing reflection on these systems and demystifying them and reflecting on and making it a priority to know how data are gathered and generated provides more opportunities for us to collectively consider the ethical implications of engaging in outreach to people living with HIV who are listed as out of care, whose privacy, security, or well-being could be put at risk through these new linkage strategies. And this isn't only just for out-of-care watch lists, but really you can extend this logic to any system where data about someone's HIV status is collected. So Georgia's HIV Surveillance Office, again, uses surveillance data to model the state's HIV care continuum. So here again is a model of the care continuum up in the left-hand corner that is produced by HIV.gov, along with the care continuum data for the Atlanta metro area, what we refer to as the Atlanta EMA down at the bottom, reflecting our rather abysmal 49% viral suppression rate. And in the top right-hand, care continuum data for Georgia. So I know that we're mostly familiar with this, but I'm going to go ahead and explain it again, just to make sure that we're all on the same page. The care continuum is a framework that's really important to understand because we work with it every day, and it's actually it's the care continuum itself. This model is the model that is used to track patterns of engagement in HIV-related medical care at the individual and group levels, to monitor rates of viral suppression within specific jurisdictions using lab reporting data held by the Department of Public Health. So the continuum is a closed narrative in 5 stages. And by closed narrative, I mean that once someone is diagnosed with HIV, in the current moment, in the contemporary way that we manage the epidemic, a person living with HIV is never able to leave the continuum. It's a narrative. And Johnny's organization is called the Counter Narrative Project. And I think that we can think about the power that narratives have. And we've seen, those of us who work with a care continuum, is a narrative that has totally, over the last several years, reorganized how we think about how the epidemic is managed. So like I said, it's a closed narrative. And by that, I mean, again, once you are in it, you're never able to leave it. If someone drops out of care, they actually just then re-enter the continuum at the relinkage stage, using tools, for example, like the out-of-care watch list. And actually now we're beginning to see the continuum. I was just at the International AIDS Conference in Amsterdam, and there's some pioneering work on this front actually being done at Emory University, where the care continuum, now we're talking about PrEP care continuum, prevention care continuums, prevention and retention care continuums, where this model, this initial 5-stage model, is being extended outward. And at every stage, as that care continuum extends out, there are also efforts to collect more and more data about how people are doing and where they are in the continuum. But currently, in our current dominant understanding of the continuum, stage 1, diagnosed with HIV, means that the state surveillance office has received a case report on a newly diagnosed individual. Stage 2, linked to care, means that the state surveillance office has received one CD4 T cell count and or viral load count from a lab for a new diagnosis within 90 days of that person's initial diagnosis. And there are actually some other ways that states get linkage data. Stage 3, engaged in care, means that the surveillance office has received at least one CD4 and or viral load count for an individual case during the last 12 months. Stage 4, retained in care, means that the surveillance office has received at least 2 labs for an individual during the last 12 months. And the standard of care is for people living with HIV is to see a provider twice a year, although many people see providers 3 or 4 times a year, and many people with well-managed HIV disease or who maybe can afford to see a doctor more than once a year see doctors just once a year. Stage 4, again, retained in care, means that they've received at least 2 labs. Stage 5, virally suppressed, means that the last viral load count that the surveillance office has received from an individual case in that calendar year was below 200 copies per milliliter of blood. So any individual, again, who is said to have quote unquote dropped out of care, and what that actually means depends on jurisdiction to jurisdiction, re-enters the continuum at the linkage stage. So there's that closed narrative taking effect again when they start reporting HIV-related labs, and it would then take them another 12 months to reach that retained marker. So the goal of data to care strategies that are executed by states is to build systems that relink people who are listed as out of care in the surveillance system by whatever metric the surveillance office has determined as out of care or needing additional linkage or maybe support services. So in Georgia, data from the care continuum are used to generate something I've been talking about called the Georgia Out of Care Watchlist. So people living with HIV in Georgia are placed on the Out of Care Watch List, or what I will refer to as the OWL. You can see the little owl there sitting in the O. That's how they represent it. People living with HIV in Georgia are placed on the OWL if they have not reported any lab results in the last 15 to 24 months. So the OWL is essentially a different spreadsheet that is culled from core surveillance data and then integrated with a couple of different systems. Individual entries in the OWL, individual people living with HIV who are listed as out of care, meaning that they haven't reported a lab in the last 15 to 24 months. So the rationale is 15 to 24 months. You ask maybe, well, why not all people who are not reporting labs? It's because they're just trying to develop a list of really targeted folks who they're likely to be able to get into contact with. If someone's last lab was 72 months ago, it's going to be much harder to find that person and relink them. So they limit it to 15 to 24 months. So the OWL is essentially a spreadsheet called from surveillance data that is then enhanced with other data beyond the case report form by surveillance personnel in order to ensure that information on each individual, such as home address and phone number, or multiple potential home addresses and phone numbers, are up to date. So surveillance staff use people searching tools such as LexisNexis, a database called Clear by Thomson Reuters, publicly available data sets held by other branches. There are a lot of different data that can go into enhancing this list, and other sources to do this work of enhancing the out of care watch list to make people who are on the out of care watch list more easier to locate. The OWL is continually updated, and you can think of the OWL as kind of the bedrock or the foundation for the state's data to care strategy. So the OWL is distributed through 2 main infrastructures. The first is called the Georgia Health Information Exchange. This is an IT infrastructure that is linked directly to the electronic health record system of 3 safety net healthcare systems in Atlanta. So when someone who's on the OWL presents for any kind of care at these facilities, an alert will go through and actually notify a team that will then attempt to relink that individual to HIV-related medical care, even if their visit that day does not have anything to do with their HIV. The second mode of distribution occurs through relinkage programs that are managed by state and local health department staff through SENS. So according to a linkage oversight manager at DPH, linkage specialists and other health staff are permitted to make 3 direct contact attempts to people on the OWL through this system. The first is a letter mailed to an individual's home from the health department and marked confidential, a call to the individual's home where a message may be left asking the individual on the OWL to call back to discuss quote unquote confidential information, or an in-person visit to the person's home. So this is a lot to take in for a lot of people, and a lot of folks just are actually rather surprised when they find out that these systems exist. And this is in part because they've been developed so amazingly quickly over the last several years. These are very powerful tools that facilitate direct clinical and public health interventions designed to relink people to care. So as advocates and practitioners, we really have to be good stewards of these systems. It's important for us to understand the full range of implications they have for the safety and well-being of people living with HIV, as well as their benefits, especially in contexts where health disparities related to race, gender, sexuality, and income and access to healthcare are extreme, where HIV stigma is still a major problem, as we all know, and of course, as in Georgia, where HIV criminalization laws are still on the books. So these are very powerful systems to get people into care, and that's been the emphasis. What we're trying to emphasize today is that we also need to be thinking on an ongoing basis about the risk. So I will now be making a normative claim that will cut across the rest of the presentation. So I would ask that everyone kind of hold it in your head moving forward. So this claim is that people who work in HIV, whether we're advocates or actually working with these systems, we have an ethical obligation to understand to the best of our ability where the data that we work with are coming from, how data are produced, how the IT systems that facilitate the storage and exchange of these data between systems are structured, who is managing these systems, and what the motivations of those who are managing those systems are. So again, I want to say this is true whether we are speaking about HIV surveillance systems, but it's also true if you're working with other kinds of systems like electronic health records, secondary research databases, careware, which folks in the Ryan White community are very familiar with, or other kinds of client management systems. So this is because, as the graphic from DPH shows, right, these systems and databases are increasingly linked together, or to use health IT jargon, they are interoperable, meaning that data now move much more easily between systems, okay? So the data that we work with are all playing a role in making the state's data to care strategy possible. And if you're working with HIV systems or healthcare systems and people working with HIV in any context, we're definitely contributing to them. So again, understanding all this will help ensure that those of us who work in the field and who are advocates possess an understanding of how these systems are constituted and what their capacities are. And as to keep an eye on them as they're changing as basic HIV science and our response to the epidemic changes. It can also even potentially open up new conversations within our communities about how our practices ought to change. So now I'm going to go ahead and turn things over to Nina.
Still here, everyone? Don't you think data is a hoot? And now you're all more qualified than that case manager from DPH who works with the out of care watch list. Thank you, Stephen, for that very extensive overview of collection practices pertaining to HIV-related data. As a person living with HIV, I can honestly say that the extent of my knowledge before preparing for this webinar was limited to name-based reporting and reporting of my CD4 and viral load count. I had no idea that people were operationalizing this on a broader scale to make assumptions about people like myself behind the data points, such as whether or not people are out of care. I only knew about the reporting to maintain eligibility for Ryan White services and to get those services. I'll certainly say that people will make these assumptions because the general public can draw simplistic and misinformed ideas about people living with HIV just because of the way we might look on paper. You're gonna have to advance 2 slides. I forgot to tell you to advance. So obviously we're my fractions. So talking like people who make assumptions, Betty Price, and back to the reflection slide. You know. Oh, okay. So you mentioned that people that are placed on the out of care watch list are there because DPH doesn't get lab results in the last 15 to 24 months. So as somebody living with HIV, I can think of several scenarios why this might not happen. Primarily, if you as a Georgia resident receive HIV-related care out of state, then it's likely that data never gets back to DPH because it doesn't come from a Georgia-based healthcare facility. As an example, I'm a clinical research volunteer at the National Institutes of Health. So I go to NIH every year in the fall to participate in research studies. Obviously, they're going to draw my CD4 and viral load. I'm not going to come back to Georgia, to Atlanta, to Emory to like get another set of labs just so to prove to the state that I'm retained in care, because that is duplicative medical spending. Like the system's paying for it twice. That is stupid. You also, if you're not a clinical research volunteer, you might go out of state to get HIV-related care because you have a doctor you really like. So again, that data is not going to come back to Georgia. And another example would be the case where somebody has left the state permanently. So I'm a military family member. I was diagnosed with HIV in 1991. I've lived in many places since 1991. And, you know, had Georgia been one of those places when I moved away to another state, you know, they would list me as out of care. I don't know how Washington, D.C. works, but if they functioned like a state, Washington, D.C. could have probably at some time listed me as out of care when I moved to Atlanta. And when I graduated from Georgetown, you know, I was like, I don't know what the lay of the land of HIV care in Atlanta looks like. My doctor was kind enough to give me as a graduation present 6 months of medication. So while I had those 6 months of medication, I wasn't like acting with the urgency to like get into medical care. I could take my time to learn the lay of the land and things like that. So these are all examples of how overly simplistic the out of care watch list is, in my opinion. And so also from those examples, the default assumption is that, yeah, people who are not in care is because they don't want to be, and they are in essence bad actors of the public health system. As Betty Price said, you know, scary how many people are out of care. It's scary how many legislators are uneducated about HIV. So I certainly agree from an ethical standpoint that I should know what data is being collected about me and for what purpose. Just because I'm the person behind the data point doesn't mean that it's beyond my comprehension, because hello, I'm talking to you today. As a matter of fact, because I can see how the data may not be measuring what we want to measure, as I explained with the cases about what being out of care could mean from a personal standpoint, I can provide valuable insight how to make these data more meaningful because of my lived experience. So I'm going to stop my commentary there, but I wanted to like put a little personal narrative, we're all about narratives here, about the things that Stephen was talking about. And now I'm going to draw attention to the fact that in addition to things like CD4 and viral load, which people are familiar with, there's actually genetic information that about somebody's particular strain of HIV that is also reported. And this is what we refer to as, next slide, molecular HIV surveillance. Apologies. Okay. I'm going to have another life example for you. So when I was actually working as a federal employee, I had a viral load spike. Within the course of 3 months, my viral load spiked from 600 to 1,800 copies per milliliter of blood, but for all practical purposes, anything less than 5,000 is pretty low anyway. At the time, because I had new health insurance, good health insurance with CDC, I was contemplating changing my HIV regimen at the time to align with the standard of care. But in order to make an informed decision as to what my particular HIV would be best controlled with, there's genetic testing that's done with my blood that you have to be detectable for in order to run this test. And this test will determine what classes of HIV medications my virus would not respond to. This is called drug-resistant genotype testing. Next slide. So molecular HIV surveillance means that the results of my drug resistance test and other genetic data about my HIV would be collected by local and state health departments. These are and if I lived in any of these other states, it would be reported. In order to monitor the kinds of HIV that are like circulating in their jurisdictions. So if I had that resistance test done in 2018, mine was done in 2011, public health officials today would have the capacity to know that I have no resistance to HIV medications, as well as what my HIV looks like genetically. Next slide. We mentioned that starting this year, all health departments that are funded to do HIV surveillance work by CDC are going to be reporting this kind of information. So the map you just saw was in the last few years. There were only a subset of states that were doing it. Now, and Georgia was not one of them. Georgia just started this year. So, and that's just started this year because it says the page was last updated June 13, 2018. So on the HIV surveillance page within the Department of Public Health, it says that all laboratories certified and licensed by the state of Georgia are required to report laboratory test results indicative of HIV infection, such as positive Western blot, that's the confirmatory test to get your initial diagnosis, all detectable and undetectable viral loads, all CD4 counts, and all viral nucleotide sequence results. That last part is like genetically what my HIV looks like. You know, if I was newly diagnosed this year, that kind of molecular information, really micro information, would be reported to the state health department. Next slide. Okay. So in a group of people that would have this kind of information reported, that is what their HIV genetically looks like, comparisons would be made among these individuals in this group to see how similar their viruses are in order to identify clusters of people, which might indicate a hot spot for HIV transmission. Because the closer the two or more viruses are genetically, like it's indicative of a recent transmission, because HIV, you know, mutates over time. So the less similar they are, like the more they're just, it's not a recent transmission. They're a little bit further removed. So I'm going to draw your attention to the figure with the circles A and B and the line between them. The line between them is a link. And so you draw a link between two people who have like very genetically similar viruses. And I want you to notice that the only arrow is the description that says link drawn between two sequences. There are no arrows from A to B or B to A. The only thing so this is very, in the general public, people want to know, can you do genetic testing in order to prove that somebody infected somebody else? I used to get this question all the time with respect to herpes. So lawyers would ask me, do we have this kind of testing where I can use it to prosecute someone? The answer is no. You only know that they're linked. You don't know who infected who. Next slide. Okay. There we go. Okay. More fun. So just as there are limitations in the interpretation of the data we've discussed so far, there are limitations to the interpretation of data collected through molecular HIV surveillance. To start, identifying a linkage between two people, that was on the previous slide, it says nothing about the direction of transmission, that is whom infected whom, and that's depicted in the top row. So again, this testing will not tell you if A infected B or B infected A. You need more information about these people, and you would need like specimens from before or after they were infected. Secondly, it's unlikely that all sexual contacts of people living with HIV will be available for this kind of testing, because some are unaware that they're living with HIV. So it's really hard to distinguish, looking at the bottom two rows, like how do you distinguish a direct transmission between two people from a transmission from a third party to both? That's the bottom right, person D infects person A and B. But maybe that person doesn't know that they're living with HIV, and since A and B are both positive, it looks like maybe A infected B, and that's, you don't know. The other scenarios from The other scenario, connecting A and B, could be in the lower left-hand corner where it looks like A infected B, but there's an intermediary through C. So you don't know any of that by comparing two viruses' genetic information. And I think that's a very strong point to drive home, because it is the assumption that because this testing exists, that you can establish directionality. And I just want to drive it home that you all now know that you can't use that. It's not, in a court of law, it shouldn't pass muster. Another limitation to this data is that it becomes even more complex when you consider that people living with HIV can acquire more than one strain of the virus. And lastly, reasons why people's genetic makeup for their virus might be similar is just because of independent processes in which HIV can evolve and mutate. So for example, if I had a drug resistance mutation in my HIV and there was somebody else that I had sex with who was also positive but didn't know it, and they had the same drug resistance I did, using the genetic information to compare us would, draw an erroneous link that says that, we had sex, but guess what? I'm asexual, so there's no way I would have had sex with that person. But in the eyes of the data, it looks like I had. So again, the bottom line when it comes to molecular HIV surveillance, evidence of similarities in HIV viruses' genetic makeups, together with clinical and epidemiological evidence, can provide support for linkage between cases, but cannot prove transmission. So, yeah.
All right. So, can folks hear me?
Yeah, we can hear you.
Great. Awesome. Okay, thank you so much, Nina, for that presentation. So now, we've gotten an overview of where how data are gathered, how systems are structured, and then sort of where surveillance is going. And so now, Nina and I are both going to talk about the benefits and risks of the different aspects of our presentation. And so I'm going to actually turn it back over to Nina first to talk about the benefits and risks of molecular surveillance, since that's fresh in our mind. And then I will go back and talk about some of the benefits and risks of Georgia's data to care strategy as it's being implemented now. So Nina, go take it away.
So while everyone's favorite molecular HIV surveillance data is on the brain, or in the case of the room, maybe Chinese food. Next slide. I'll say I borrowed some of these slides from CDC. That's one of the perks of previously having worked there. So I'll just make the disclaimer that the benefits to molecular HIV data, these are the benefits according to CDC, and as you would imagine, that it's for primarily public health purposes. I talked a lot about drug resistance, so that the molecular HIV surveillance data will tell you how much drug-resistant virus is in a community, whether it's been recently transmitted. It'll look at all kinds of different HIV that exist within a community. It'll help you understand transmission patterns. And that's through that network of linkages. It's not, again, not going to tell you so-and-so infected so-and-so. Molecular HIV surveillance data has been used to look at suspected outbreaks. For example, I think people are kind of familiar with the HIV outbreak that happened in Indiana as a result of injection drug use. They use molecular HIV surveillance there in order to detect that boon of new HIV cases. So once they have those, they can trigger investigations and interventions. You can do outbreak investigations over time, identify groups of people and networks with active transmission. So again, you don't know anything on the individual level. And you can use these data to prioritize prevention efforts. So I agree that there are good public health uses for these systems, but as a person living with HIV and as a person living with HIV who lives in a state that criminalizes my HIV, there are some risks. Next slide. So molecular surveillance data is not protected under federal privacy laws and is subject to subpoena in Georgia. They will release my HIV data, my CD4 count, my viral load, my genotype resistance testing, if there's a court order to get that information, and I can't do anything about that. Now, given that, this was an extremely engaging talk that was, simple as hell, just kidding. This is all a lot of information, and it's all very complex. And the fact that someone can just get, for example, what my HIV looks like genetically with a court order, there's a high probability of them misinterpreting the data. They're going to make that default assumption that, oh, I can get directionality through this kind of information and show that Nina infected so-and-so. That's not the case, but the point is that because they subpoenaed that information, it goes onto a court record, and it stays there for other people to misinterpret and misuse. So, we live in a state that criminalizes spit. I don't have much confidence in what happens to my information if it gets into law enforcement's hands or in the judicial system. And I covered I love lawyers, but some of them will try to put me in jail. So I'm aware, but I love the lawyers in this room. I think it's over to you.
Okay, thanks very much, Nina. And so I'm going to take us back here to a discussion of the benefits and risks of the existing out-of-care watch list and the state's data to care strategy as it exists now. And I'm just going to kind of let these slides, this visualization, which comes from Jane, a poster presentation by someone who administers the state's HIV surveillance system that was actually part of the American Public Health Association annual meeting in 2017 that happened in Atlanta. This is taken from a poster there. And I'm just going to kind of let this slide speak for itself. So, there are a lot of benefits to data to care, and actually folks refer to data to care systems. They're evidence-based in the sense that they're evidence-based in that they do get people linked to care, whether or not that translates to long-term engagement and retention in care. That's a different story. The data are less clear there, but they do do a good job at getting people linked to care. And so that's the main benefit. But there are also these other side benefits, such as here this visualization talks about improved clinical systems. So people who are implementing these systems can develop a better sense of how to move data between systems, develop ways of getting data to move faster, which might actually not be a benefit. But overall, and again, this is framed as a benefit by the public health system, and I think it's true that it is good to have coordination, particularly regarding the delivery of HIV services, which we all know here in this room we have tremendous problems with in Atlanta and many other jurisdictions in getting people into care and giving them services in a way that is fast and efficient. Establishing data to care strategies does help with that, because it requires building systems that require people who might not often talk to each other to talk to each other, such as the IT department at a clinic and the state's Department of Public Health. These systems get people to talk to folks, but really the real benefit here is getting people linked to care. All right, so now I'm going to talk a little bit about what the risks are, because I want to emphasize that there has been discussion. It's not like these systems were built blindly. There were discussions about ethics, and if you go to the state's website about the HIV Health Information Exchange, The members of the ethics work group are listed there, and there have been ethical considerations of out of linkage to care programs and data to care. However, there, in my estimation, and I think in a lot of the conversations I've had with folks, the potential risks of data to care have not been fully fleshed out. And that's what we're trying to do today as part of this broader practice of reflecting on what it is that we're doing when we work with these systems. So the first potential risk that I'd like to talk about is outing someone, either as living with HIV, as a queer, gay, bi, trans, as something like that, in the context of extreme stigma or maybe like a marginal housing situation. We could imagine someone in rural Georgia, perhaps a young Black gay man who still lives at home or lives in a precarious roommate situation. In a situation like that, even though when health department staff come knocking at the door or call in or send a letter marked confidential, in a lot of these contexts, right, this is not exactly going to be discreet. Even if the person isn't out of the closet, people coming around knocking from the health department, that even if they are taking all best efforts to, of course, not disclose. Well, there have been incidents of disclosure recently, high profile in the news. Like, for example, when Grindr disclosed, it was disclosed that Grindr was disclosing people's HIV statuses, although that has nothing to do with data to care. You can out somebody either as living with HIV or as possessing a marginalized identity as a member of a risk group very easily, even if you're not actually saying it. And that is a problem that I think that we need to be talking about more with the folks who administer these systems. The second is the increased likelihood of criminal prosecution under state criminalization statutes. So we know because of this wonderful Williams Institute report on HIV criminalization in Georgia, produced by the Williams Institute, that, particularly that I think it's over 1% of folks in rural Georgia have experienced some kind of prosecution related to their HIV status using these laws, and that in some counties that number is as high as 10%. So 10% of people experience some kind of prosecution in parts of Georgia because of their HIV status, right? So again, in this work of demystifying data, this data from the Williams Institute report is actually quite limited and captures only a very small portion of the kind of interactions that people living with HIV have with law enforcement, because it only captures folks who are prosecuted, right? It doesn't capture folks who may have been interviewed by the police that didn't lead to prosecution, and other data like that. And we know because of work that there's a cover on the right-hand side of a book called Punishing Disease, which I encourage folks to read, by Trevor Hoppe, who's a sociologist who is deeply involved in the HIV Justice movement, that there are documented cases, but not nearly enough research about there's not nearly enough research about this, but there are documented cases, some of which we know about here, of public health department staff working with not just prosecutors but also police in some of these issues where there may have been non-disclosure or rumored non-disclosure or something like that, and we don't have data about that. But if we know that HIV prosecutions are happening at that rate in parts of Georgia and in Georgia in general, rates of casual contact with law enforcement are going to be higher. And we need to keep an eye on that and be aware of it. It's a huge risk posed by these systems. Another point is potential coercion into medical care during relinkage processes. So I'm going to say something about this, and I'm actually going to let Nina talk about this as a person living with HIV. I'm HIV negative, and so I'm not as qualified to talk about this. But I want to say that we talk about linkage to care, but coercion into medical care during relinkage processes is an issue that we have to be aware of. Folks who are going to be on the out of care watch list. These are the most marginal, going to be some of the most marginalized people who are affected by the epidemic. And if they might not be ready to re-engage in medical care, these are folks who are often not going to feel empowered to speak back to someone, a medical provider who is standing there telling them that they need to do something about what is right for them. That can be a very disempowering and potentially coercive scenario. And Nina, I want to turn this over to you to say some words about that, about elaborating about why folks, because for a lot of people who manage these systems, that it might not be the right time for someone to relink is a little bit out of the realm of conceptualization for a lot of people who manage data to care. Nina, can you talk about that for a sec?
I don't know if you guys remember there was like a whole push behind test and treat, and you saw it on like posters and flyers and buses. And like when I first saw that, like to me, that just sounded coercive because, after somebody gets tested and knows they're positive, you're like, and now you have to treat them. Like they don't have a choice. Like they can't build self-efficacy to learn how to be what's going to be called a good HIV patient, because these are people who are probably healthy before they were diagnosed as HIV positive, and now they have to do all of these things as an HIV positive person in order to be seen by society and public health people to be like a good actor in the public health system. So when you talk about linkage to care, for me, I always cringe because it sounds very paternalistic. Like, you should give people the benefit of the doubt that they'll enter into the system when they are ready. A lot of people, I wasn't diagnosed at an age where I knew to be crushed by it, but many people living with HIV are diagnosed as young adults. They go through this grieving period, they're paralyzed, the last thing on their mind is engaging in medical care. But that doesn't mean that they don't know 6 or 12 months down the road, they may be ready at that point, but you just have to give them some time. So that's what I have to say about the potential coercion, both during linkage to care initially and re-linkage to care.
Yeah, and also, folks living with HIV, as Nina mentioned, folks living with HIV know what their medical needs are and are also the ones who are best empowered to make the determination on when it's best for them to get into medical care. If someone knows that, well, they're not in a stable housing situation, or they're not in a safe housing situation, they don't have a place to store medication, they don't have regular access to food, so how are they going to have access and ability to take care of their meds? But they're working on that. And in 6 months, they plan on, going back to the Ryan White Clinic where they are to get in care. There's going to be a lot of pressure on those. There is a lot of pressure, I know, because I've talked to folks about how these programs are administered to relink those folks and get them on meds, which, I like at that time right then. But they know, folks living with HIV will often have a plan to do that later, even if they're not doing it right then. But it can be really hard to speak back to the medical system, as we know. The final point is, I say harassment, and that might be a strong word, but, by public health officials or increased experiences of stigma or fear. So, the 3 initial contacts that someone can make if they're on the out of care watch list, phone call, with a message left, a letter sent, or a home visit, these are just initial contacts. So if someone hesitates, or if someone is contacted, let's say, and enters into a case management relationship with a relinkage navigator or someone at a health department, the consents that they sign, provide really broad latitude, for the case managers and the relinkage staff to, contact them a lot, stay in regular touch, more and more contacts with the healthcare system, whether or not the person is actually engaged in care. And if they're not engaged in care, these contacts happen over and over and over. And actually in the model used called ARTIST by the state and local departments of public health in Georgia, you actually don't ever leave. It's another one of these closed systems. You don't ever leave case management. You go into what's called long-term case management, which I think is actually really hard to get out of. And so that, of course, increases potential for outing, just contacts with the healthcare system, and potentially, has the potential to increase someone's experience of stigma related to their HIV. So that is, what we have had to say today, and we're going to end with some calls to action. And I will actually turn that over. I'll say the first two. So the first call to action here is that stakeholders need to stay aware of what state HIV surveillance offices are doing with their surveillance data. We need to more purposefully hold the guardians and operators of HIV surveillance systems accountable to the ethical development and application of these systems. And I will make an editorial remark that I really don't think that the current ethical best practices in place are rigorous enough to ensure the safety and well-being of people living with HIV. And Nina, I'll turn the last 2 points over to you.
I'm sorry, I'm still thinking about your one bullet where you wrote the term harassment. And as you were talking about those processes, I just thought, oh my gosh, the person who's coming to my door 3 times to really link me into care is like a process server for medical care. So I think harassment is quite fitting. Anywho, so we need to consider what proactive limitations might be placed on the use of these data. Again, there are not a lot of limitations. All you need is a court order. And future efforts to change Georgia's HIV criminalization law should include efforts to protect data from subpoena and reduce the likelihood of misuse and misinterpretation of such data. Next slide.
Yay! All right, really happy. So Nina and I are ready to take questions about this really positive, joyful content that we've gone over today. Thank you all for listening so much.
Wonderful. So for those individuals who may be joining on the webinar, I am going to, we've gotten a thank you. So we got a thank you to Nina and Stephen for this presentation. So they mentioned that this was so helpful. Thank you so much for that, Robert. Are there any questions in the room? We have about 5 minutes left.
It also might take some time to unpack all of this information. So I know that we're going to have a recording of this webinar, and if through reviewing the webinar you come up with questions, feel free to reach out to me and Stephen. And you know what? We probably just answer them in the Google listserv to make sure that everybody knows what that question is and what the answer is, because I think it could be of use to all of us.
Absolutely. So thank you so much for your comment, Robert. And thank you so much, everyone, for joining us this evening for this webinar. Thanks to Nina and Stephen. And for those individuals that may watch this webinar, you can send us email to Georgia HIV Justice, and we will make sure that we get your question or comment to Stephen and Nina. And thank you so much for joining on the webinar this evening.